Last time I gave grand rounds at Stanford Surgery, I talked about actually the PAUSE trial, which Dr. Lee mentioned briefly. But that and part of my growth as a surgical investigator in health services research has been about, how do we incorporate pragmatic trials into surgical practice? And hence, I figured today I'll talk to you about some examples of pragmatic trials and what I think could be the future of health systems interventions, especially around surgery. These are my disclosures. So many of you know I've spent my early career talking about and studying frailty. And this background is just to give you an idea how I got to pragmatic trials research. So through my early career development awards, I figured out that, hey, if a patient is frail, that is a definitive geriatric syndrome and goes beyond geriatrics. You could be young and frail, but they have low reserve to tolerate surgery or any stressor, whether it's anesthesia, it's minor surgery, major surgery. And that led to development of a surgical frailty screening tool called the Risk Analysis Index, which is shown here. And I'm drawing this out right now just because I'm going to touch on this later, is that frailty is multi-domain. So it's not just about somebody who has a lot of comorbidities, but they also have deficiencies or deficits in other domains like cognition and function and social status and nutrition. And so if you measure the deficits that accumulate across these domains, you can actually measure frailty. And so I developed this tool as part of my career development award. And I wrote a lot of papers in the first few years of my career, initially showing that, hey, frailty is bad, lots of different ways, what sort of outcomes it impacts, whether it's in vascular surgery or overall surgery in general. Then, as I talked about, we developed this tool, we validated it in multiple databases and prospectively. I think it's been validated now on at least 2 million patients overall, if I put all the studies combined from different registries and prospective databases. We also showed that it doesn't matter whether you're having a small surgery like a hernia, or you're having a Whipple, or you're having a carotid or an EVAR. Every specialty is affected by poor outcomes associated with frailty. And we've also shown that, yes, you can actually integrate it into clinical workflow, and what are the ways to do that, whether you're in a VA healthcare system or you're in a private healthcare system. But throughout all of this, as you can see, years of work, it was clear that there was always some resistance to overcome. There was always some naysayers or some resistance from health systems that, hey, if it is so obvious that frailty is bad, why aren't we measuring it and doing something about it? And so that's what led me to a realization that, much like bench science in health services research also, we have a failure of translation. You can make the best predictive models, and the RAI in most registries performed at a C-statistic of 0.8, which, we use ASA class and CHAD score and those kind of models. Their C-statistic is 0.6. Still, we use them in clinical practice. So why aren't we getting adoption into clinical practice? And much like bench science, there's this valley of death where all these predictive models go to die unless you can prove that there is clinical utility and you can show that how it can be adopted into clinical practice. And that bridge is essentially pragmatic trials or implementation trials or improvement science. And that's why as surgeons, we need to think about, hey, we can develop the good tools, we can develop local specific clinical quality protocols, but if you want to make it generalizable, you have to do more. So my goal for this talk is going to be, I'm going to touch on the differences between pragmatic and explanatory trials. I'm going to give you 3 examples of different trial designs that I've been involved with, so I can speak from personal experience. The first being a cluster randomized trial called PROVE AAA. The second being a step wedge hybrid design called the PAUSE trial. And then a registry-supported trial that Dr. Lee mentioned, the Warriors trial for women with aneurysms. So let's get started. So traditional clinical trials, we know that in terms of the pyramid of evidence, they are at the top of that pyramid. If you want to prove conclusively that some intervention works, you have to do an RCT, and then multiple RCTs lead to generation of clinical practice guidelines or meta-analysis and systematic reviews. But traditional clinical trials that have been run for decades are very strict controlled trials. So they have very strict eligibility criteria. They often have good internal validity but poor external validity. So it makes their clinical applicability limited because a lot of the patients that you see in everyday practice may not be included. An example being one of the important carotid trials, the CREST trial. It excluded patients who had chronic kidney disease, high stage, or it excluded patients who had concomitant atrial fibrillation. What is the percentage of patients we see in our practice that have both of those? It's about 30%. So we can't apply those results to the patients we are seeing in everyday practice. There's also selection bias. A lot of these trials end up going to sites which have, siloed patient populations, high trial infrastructure, but not necessarily out in the community. So traditionally, clinical trials have suffered from selection bias. There's a lot of non-adherence and attrition of participants due to strict trial protocols. The cost and complexity of these trials keep adding up. And there's also potential overestimation of treatment effects in controlled conditions, and in real-world settings, you may not find that same efficacy. A lot of trials capture a lot of data. The amount of case report forms and administrative burden that's associated with it makes it really hard for sites to actually be able to afford to be part of these trials. I read in a thoracic trial review that in the primary analysis of trials, they looked at data for over a decade, that only 20% of the data collected actually got published from these trials that were conducted. So that's where the role of pragmatic trials comes in. How can we make trials efficient? How can we make them more applicable to our general practice? And so pragmatic trials inform a clinical or policy decision by providing evidence for adoption of the intervention into real-world practice. So they have high external validity, they will have large sample sizes, they won't be as complex or as rigid, and will have more diverse settings. Explanatory trials, on the other hand, they confirm a physiological or clinical hypothesis, and they have a very important role, especially in phase 1 to 3 trials. You cannot move on to a pragmatic trial if you don't show the efficacy of the intervention that you're testing. But if you want to define what is a pragmatic trial, there are 2 key attributes. One is that it is trying to inform decision makers, whether it's patients, clinicians, or policymakers, as opposed to elucidating a mechanism or a mechanistic trial. And it's trying to enroll a population that is representative of the patients in clinical settings for whom the decision will be relevant. So it's not a one-size-fits-all. It's not that your trial is either pragmatic or explanatory. There will be components of trials that will be more mechanistic versus pragmatic, and there are actually tools out there that can help you determine on what sort of continuum do you lie, whether you're more pragmatic, the degree of pragmatism or level of pragmatism can be assessed with tools. So with that background, I'm going to talk about first the PROVE AAA trial, which was a cluster randomized trial design that I was involved in. Dr. Phil Goodney, one of my early career mentors and now dear friend and collaborator, he was the PI of this trial. It basically tested that, if we were to give patients a decision aid for open versus endovascular aneurysm of repair, what would they choose and why? So this was the trial design where veterans who were eligible for both repairs were actually randomized into sites. So the cluster randomization happened at different sites. There were 20 sites across the country that were involved in it, 20 VAs. I had the distinct pleasure of being site PI for 2 sites. So not only did I run the trial in Atlanta, when I moved to Palo Alto, I started that up as a site, and we finished data collection for both. So the control sites basically had that the patients filled out a repair survey, what would they prefer. Then they underwent their vascular surgery consultation, and then the surgeons filled out a survey, and then we looked at a decision process score of how well the repair actually matched the preference voiced pre-op. And the intervention sites, they had a pre-survey along with a decision aid where a coordinator went through the decision aid and gave this information to the patients, and then they had their usual vascular surgery consultation, and again, we had surgeon surveys and a decision process score. So the aims were to see that what are the factors that are associated with a decision of endovascular versus open, and to determine how well a decision aid helped to provide preference concordance care. So here I'll talk a little bit about the cluster randomized trial need. Why do we need a cluster randomized trial? Can't you just randomize patients, give one patient a decision aid, one patient not? The issue comes up is when you have health systems interventions that can cause contamination. So if you train a surgeon or a health care provider on the use of a certain health education tool or the decision aid, what if they start using that on patients, they like it, and they start using it on all comers? What if they unintentionally start using it on control patients as well. So where you can't afford contamination for your trial results to actually be valid is where a cluster randomized trial is very useful. So it aims to prevent contamination by randomly assigning hospitals or clusters or providers to the intervention or usual care, and thus making the results more valid when patient-level randomization is not what you're interested in. The drawbacks are treatment differences could actually reflect site differences or cluster differences. So how do you account for that? And case mix may vary by hospitals or clusters, whatever cluster you choose. And power is dependent not on the number of patients. So in traditional power analysis, you look at, what is the effect size you want and what is the minimum number of patients that you need to achieve that level 1 error or avoid level 1 error, and that's all. But for cluster randomized trial, not only do you need to take into account the anticipated effect size, but also how many clusters do you need that have enough variability that you could get the power that you need. And you could keep adding more patients to a cluster, but it's a law of diminishing returns there. For this trial, for instance, for proved AAA, we only needed 12 patients per site, but we needed 20 sites to achieve the power to answer that question. And the measure of how homogeneous the sites are, it is measured using something called intra-cluster correlation coefficient. And this is something actually you can get with the help of any senior statistician. Aspire actually has consultative resources, and they helped me calculate some of this for my own trial. So there are ways of minimizing bias in cluster randomized trial because essentially it's unblinded. The sites know which one is the control and which one is the intervention. There are some good data out there to show how to reduce bias in cluster randomized trial. The first and foremost being you should recruit sites which have equipoise, which are willing to randomize, and because once they are randomized, they will know whether they're a control site or an intervention site. And then as we talked about, that there is variability within sites, so how do you adjust that for analysis? And those are important key considerations when you think about bias in cluster trials. So what did we find in proved AAA? We found that patients, when they were exposed to a decision aid, they were more likely to receive their preferred AAA repair. So the kappa coefficient for the decision aid was 0.78, whereas for the control group it was 0.53. So a decision aid can help align patient preferences and treatment of major cardiovascular procedures. What was interesting also that what were the factors that influenced the choice of the repair? A majority of the patients actually did not have a preference. They came in undifferentiated. Even after the decision aid, a lot of them stayed undifferentiated. And one of the factors that was why patients preferred open was they were concerned about long-term reinterventions and complications. And those who valued a shorter hospital stay and shorter recovery, they preferred EVAR. But knowing that a lot of patients didn't know pre-post decision aid, one of the biggest factors was the advice of the surgeon, and that was very important. So it was a key takeaway for us that veterans, especially in this trial setting, they relied heavily on the advice of their surgeons, and you have a very important role to play in terms of how you steer them and how you consider decisions regarding their risk profile and what social support they have and how they recover, and long-term whether they would have good outcomes. Whether we would find the same findings in a private setting, I don't know. Well, it remains to be seen because endovascular repair has pretty much overtaken open repair in a lot of private settings. All right, moving on to the next example, the PAUSE trial. So this is still ongoing, but in the last year, and we are at the phase of analysis. So this is a stepped wedge cluster randomized trial. This was a hybrid effectiveness implementation trial. I was fortunate enough to lead this, conceptualize this, and I've learned a lot through the process of this trial, and I'm happy to share some results with you, but I don't have final trial results because we are still waiting on primary endpoint. So the overview of this trial, the overall trial aimed to test the effectiveness of a frailty screening and optimization, multidisciplinary optimization intervention versus usual care, and improving outcomes for patients being evaluated for elective surgery. So this is something that we are measuring frailty as well as referring for optimization before the surgery happens. So in our analysis, we will have patients who were evaluated for surgery and eventually did not have surgery. So I think that's an important consideration. That question keeps coming up, that what if we just look at post-surgical outcomes, what about the patients that were too frail to even have surgery? So we will address that. We designed it as a 3-site trial, but 21 clusters. So Palo Alto, Houston, and Nashville VAs are a part of this, but each site has 7 clusters. So as I talked to you about the cluster randomized design, the power depends actually on the number of clusters, including differences between clusters. So how different are the clusters? Are they homogeneous or heterogeneous? And then number of patients per cluster. So we included 7 different surgical specialty clusters. We combined cardiothoracics and plastic and ENT for power considerations. But you can see at all these sites, number of patients have been included in this trial. And as we are doing the data cleaning, we have a cohort of about 35,000 veterans that will be part of this analysis. This is the conceptual design of the trial. We bring together, after patients are screened frail, they're referred to a multidisciplinary board that has representatives from surgery, anesthesia, geriatrics, palliative care, nutrition, rehab, and case management. The idea being that if you bring people together, experts together around the patient, you could optimize them and improve their outcomes. So aim 1 is the clinical effectiveness, as we talked about, with the primary outcome of 6-month mortality, but we are going to look at a whole host of outcomes. Aim 2 would be by frailty status or by risk status, does that effectiveness hold? And whether there's differential improvement in frail versus non-frail or high-risk versus low-risk patients. And aim 3 has been the formative evaluation that I'm going to touch a little bit more on, because I think this is an important idea that could be implemented in other surgical trials that look at hybrid designs or implementation designs. So we had evidence, efficacy data, as you saw from a lot of my publications, that frailty screening works. What was unknown was how do you build an intervention around it. And while we did not have efficacy data on the multidisciplinary care, there was data in literature that we used to support this design. You have tumor boards, you have chronic care conditions where multidisciplinary care works well for patients. And so that baseline data served as the theoretical efficacy or validity for planning this intervention, because we knew that identifying frailty and discussing it is important, but in what format and how do you actually discuss it was part of the adaptation of the trial and being tested as part of the implementation of the trial. So that's an important difference. For those of you who may be familiar with this book, Atomic Habits, anybody has read that? Yes. So in chapter 1, actually, they talk about marginal gains theory or marginal gains concept. What that says is that if you make even 1% incremental gains in multiple areas, you can actually make a magnitude of gain. And the example was like a British cycling team that ended up doing lots of minor changes and ended up winning becoming the leading team in the world. And this has been advocated in lots of other health sectors, business sectors, as well as healthcare. And so this is the basis of what we said, that as you recall, RAI, or the frailty tool that we developed, it is multi-domain. So if you make improvements, marginal improvements in each of those domains, or some of those domains, those marginal gains across that would result in substantial benefits in individual patients undergoing major surgery. There have been trials that have tested individual interventions. What if you change the anesthetic? What if you change the nutrition? What if you change the exercise? And those studies have been largely negative or with faint positive signals, and that served as our justification that if we bundle that care, if we combine the marginal gains, we will get a net total positive gain if we do that. So this is the pause intervention cycle. So we started with usual care. Because this was a hybrid trial, we wanted to collect implementation data. So we started with interviews and focus groups during the usual care phase. Then as each cluster was randomized, there was a transition phase of a quarter where we actually taught them how to do the screening, how to put in the orders for pause board consults, and how the pause board meetings would be run, and setting up the multi-stakeholder groups. And then we moved on to the post-intervention phase. During the intervention phase, we've been doing site notes. We've been collecting feedback on how things are running. We've been providing weekly audit and feedback reports to all the sites and the clusters that are being randomized and how they're doing, and I'll share some of that data. And then right now we are in the post-intervention phase, where we're doing actually post-intervention interviews and focus groups to see what worked, what didn't work, was the trial intervention as expected, and what could be improved. And of course, the analysis is going to happen after that. This is the randomization schedule. So we started in May 2021 at the peak of COVID, had to make a lot of changes to the trial itself to make this work. But all the clusters, as you can see, have been randomized across the 3 sites, the 21 clusters. We had a staggered start because of COVID and regulatory delays. So that is another thing that we'll have to take into account as we analyze this trial. But right now we are in January 2025. We are doing our post-intervention interviews and focus groups, and we'll be analyzing this data. So talking about the step wedge design, when to use it, why, and where is it helpful and not helpful. So in a step wedge design, different clusters of participants are randomly assigned to crossover at different time points in the trial. And that's why I wanted to show you the schedule and how each specialty is serving as its own control. Some specialties contribute longer to the control data. Some specialties contribute longer to the care data. But that's where the inherent differences between the specialties and the ICC becomes important in the analysis. And also, there is an important thing to consider is the time trend. So over time, intervention may change. People may come and go. So the secular trends also have to be accounted for in the analysis. But what it does do is it ensures everyone will have access to the intervention. For us, we couldn't imagine telling an IRB that half the patients will not get an intervention if they were identified as frail. So the step wedge design made sense for us that eventually each site will get the intervention for frail patients. And it facilitates research when it's embedded within usual care. So particularly when it is ethically appropriate not to take individual level consent. So if a patient is high risk, why wouldn't we give them a chance to be optimized? And IRB, our ethics board and IRB and the data safety monitoring board all agreed that, yeah, we do not need individual level, patient level consent here. We are implementing an intervention that would be beneficial as shown by prior data, as well as the feasibility studies that we've done so far. And patient-level randomization is impractical in such a situation, especially when you're developing a multi-level intervention. And it's ideal for adaptive design. So if you're trying to adjust an intervention and work out the kinks, a step wedge design is actually useful because as your intervention arm grows, you have worked out the adaptations that would be helpful for making your intervention successful. The pitfalls, as we talked about, there's secular confounding. So there are background trends that may be happening that are influencing treatment effects, so that have to be accounted for in the analysis. The clustered nature, as we talked about in the cluster randomized trial, there are issues around methodological concern and bias, so that have to be addressed. And there will be repeated measures. Some patients would be in your usual arm at one time and in the intervention arm at another time. So how do you account for that in your analysis? To maintain internal validity, you have to account for the potential imbalance between study arms and baseline and prognostic characteristics. It can be longer than a parallel arm design, and when the clusters are relatively homogeneous, it may be better to do the parallel study actually and not to the cluster randomized step wedge design. So this trial is also a hybrid trial. What does that mean? Whereas pragmatic trials essentially focus on clinical effectiveness, if you add a layer of understanding implementation, how do you make implementation generalizable and in a way that is scientifically reproducible, that's where hybrid trials come in. So not only would you study effectiveness, but you also would study implementation. And there are different types. So our trial is a hybrid type 1, which means our primary aim is effectiveness, but we are studying implementation. What are the potential barriers? What are the facilitators? Because one of our aims is to create a national implementation guide after this trial is over so that the National Surgery Office at the VA can take this intervention and scale it up to 150 VAs across the nation. We'll see whether that can be done, but our hope is that. Hybrid 2 trials are co-primary aims. Usually you're studying effectiveness and implementation to the same degree. And hybrid 3 trials are mainly implementation trials, and the secondary aim could be to confirm effectiveness or see that if it is truly effective in a larger design. But that's the continuum. So in hybrid trials, you usually will find, there's a core design element and there's an adaptable design element, and that's what we did. That there were certain design elements of the trial intervention that could not be morphed. We couldn't tell the sites that, oh, it's okay not to do screening for certain patients or not to do the referral for certain patients. So the core elements were patients are being screened and they are being referred for the pause board, and that has to stay constant across all the 21 clusters and sites. But the adaptable elements were who could do the screening, whether it's which surgical team member or whether we are going to employ nursing or MAs or LVNs. When to do the screening? Are we doing it for all comers in the clinic, or are we doing it at the time they are having their discussion with the surgeon, or are we doing it at the time that they are actually being booked for the case? Also, how the pause board would be run. That was a big unknown, as I told you, that we didn't have efficacy data on that. So how comprehensive would the assessment be? Who are the PAWS board members that are absolutely essential, whether they can attend remotely versus in person, or can we get asynchronous recommendations for optimization by email versus in-person meetings? And how should the discussion be run? And how do we communicate back those recommendations? And what are the things we as the trial team could help with implementing versus what the sites or the specialties wanted to control? Maybe they did not want us to replace a referral to geriatrics or palliative care. We wouldn't touch that if that's what they wanted us to do. So how do you inform what are the core and adaptable elements and measure that progression, and how do you identify adaptations and actually implement it? That process is called formative evaluation. There are a lot of trials who do process evaluation, but there it's mostly a passive sort of observation of, okay, how are things being implemented, but you're not actually changing how things are being implemented. In formative evaluation, you use rigorous assessment process to identify the potential influences on the trial, and then you identify modifications of those interventions to optimize your implementation strategy, and also analyze the causal events that led to the change in specific components of the intervention that most influenced outcomes. Like if we did this adaptation, this had more of an effect, and if we did a Y adaptation, it actually did not change the outcome at all. So that process, that entire process is called formative evaluation. It has many phases. It could be developmental. In our trial, the developmental formative evaluation was the initial site interviews and focus groups, where before we even started, we knew what were going to be barriers and facilitators, and how could we think about overcoming that, and what sort of adaptations we could propose. Implementation focused and progress focused formative evaluation is when you collect site-specific data, you collect data during onboarding, and when you're doing your weekly reports and giving audit and feedback reports to the sites, how is that changing their behavior? And interpretive is, once all the data has been collected, we synthesize it all together and see which adaptations worked, which didn't work, what were barriers and facilitators for the overall implementation of the trial. And we used what's called a CFIR framework. This is a common framework used, Consolidated Framework for Implementation Research. That's the full form. So it's a common framework used for implementation studies, but it is very intense, and it is complex because it has 6 specific different domains that you have to consider as you plan the trial and as you collect the data for analysis. So you have the innovation, which is the intervention for the PAWS trial. Then you have the outer setting, which means that not where you're actually implementing the trial, but the overall setting in which the trial is functioning, which is the overall healthcare system or the overall site, the other specialties like medicine, or which are not entirely part of the trial, but would impact the outcomes. Inner setting is our surgical specialties that we're actually implementing the study. And process is, what we established in terms of screening as well as referral, and then recommendation, communication. Individuals involved, there were lots at multiple levels, whether it's surgical or nursing leadership, mid-level personnel, trainees, patients, and then the expected outcomes, not just the effectiveness outcomes, but also the implementation outcomes, which are fidelity, like how closely was the trial implemented as intended, and what sort of adaptations we had to do. So as part of our developmental FE, which was the initial pre-implementation interviews, we identified a lot of potential barriers and facilitators. So what we found was that you have to identify champions within each of those specialties to be able to get this to be successful. And we gathered data on adaptations for each particular specialty. The common barriers were limited time, staff shortage, and concern that would this delay surgery. And nurses who were initially not part of one of our intervention execution partners were identified as a very important partner, and then we engaged them after this initial developmental data analysis. We also identified surgical and nursing leadership was very important in engagement to adopting any new intervention. And we also identified multiple variations, not just within specialties, but also within sites that would influence the implementation process. I want to share some implementation and progress-focused data. So this is the audit and feedback report we were sending the specialties. So we were sending them over the course of time of the trial. The black was the screening rates. How good are you doing in terms of screening the patients that are coming to your clinics and being booked for surgery? And the red bars were how often are you sending the patients to be discussed in the PAWS board. So as you can see, 80% was our threshold for success. And in this example, this specialty, I've come up with 4 phenotypes, was a believer. They were like, yeah, we believe this trial is important. We believe in the intervention. They started out the gate when they first got randomized around February of 2023. And then they had high screening rates and high referral rates. Then we had the slow adopters. We found a pattern where people would start off slow, but then as we worked with them, identified adaptations and identified champions, we were able to increase their screening rates, and we were able to get them to a point where they were consistently sending their patients to the pause board. But then we had some apathetic participants, as I'm labeling it. Happy to think of some other names. This is still being analyzed, where some specialties just had a steady stream of screening rates, and they were not interested in improving it further. They were happy to participate, but not necessarily interested in making changes to their own clinical workflow to make that happen. But when they identified frail patients, they did send some patients too. And this was rare, but there were some non-believers out of the 21 clusters where they were not interested in screening. When they were forced to screen, they did, but they never sent anybody to the pause board. So as you can see, the feedback as we provide, there are people who believe in the innovation, and they are susceptible to intervention and feedback, but there are others who are not. And there are many factors that influence that. Currently, we're actually analyzing these trends by looking at, could we have picked up who would have behaved this way using the pre-implementation data? Because that would be an important contribution to literature, like if there was a framework we could develop where you could identify with your initial interviews which would be good sites or good clusters to randomize, which would not. So more to come on that. But as you can see, this trial is the effectiveness data. I don't have it to present right now. We'll hopefully have it in the fall. But hopefully it'll influence and bring light to how can we do these large health system intervention trials and whether frailty screening and optimization does work. And this study has been a huge team effort and lots of support from the national branches of the National Surgery Office, geriatrics and extended care, and hospice and palliative care. Okay, so the last trial that I'm going to touch on briefly is the Warriors trial. And this, as Dr. Lee mentioned, this is a trial about women's aneurysm research, and it is actually an international trial, and U.S. is a part of it. I had the fortune of being approached to be the USPI along with Adam Beck and Jeff Schakowsky, who are both at University of Alabama. I'd like to thank Dr. Dahlman's sponsorship and actually getting me introduced to the international PIs so we could be the national clinical coordinating center here at Stanford. So this trial is still under development. It has been approved actually and funded in Britain as the international CCC and DCC, but all the countries have not yet secured funding, including the United States. So the premise of the trial is that women with abdominal aortic aneurysms are not the same as men with abdominal aortic aneurysms. But if you look at traditional size criteria, which is how we define how an aorta is aneurysmal, the prevalence in women is much lower. But if we actually account for body size differences, prevalence in women may actually be higher, around 6%, as opposed to the 1% that is usually coded. And women with family history and smoking history actually have comparable prevalence as men, and there's lots of observational data to support that. While over time there has been a steep fall in overall aneurysm-related mortality in men, women's mortality over the years, since 2 decades, has actually not improved. In fact, consistently we found that women who undergo endovascular or open aneurysm repair have worse outcomes than men. And why is that? There is lots of data out there. We also, a group of interested investigators, we did a comprehensive evaluation of frameworks, and there's not only just the choice of the therapy, but also poorly understood natural history. Women are usually older at the time of diagnosis. The device studies that have been used to develop endovascular devices actually have mostly just tested it on men. We don't know if they are as efficacious in women. There are anatomical differences. Women's aneurysms at the same size tend to be more tortuous and lose what's called EVAR eligibility because their proximal neck actually degenerates faster than men. And there's also data that in an emergency, women will actually be denied or not necessarily denied, women are less likely to undergo repair. Some of it may be patient preference, and some of it may be provider bias, and it's unclear which one of those it is. So at the size that we treat men, which is around 5.5 centimeters, the aortic size index, which adjusts aortic diameter by body size, is actually higher in women. So the question is, are we treating women too late because their aortic size index is actually worse at the same size diameter as men? And if you look at the rupture risk of a 5.5 centimeter aneurysm in men, the same rupture risk exists for a 4.2 centimeter size aneurysm in women if you look at modeling studies and pooled observational data. So there's a 4 times higher risk of rupture at the same size threshold. And risk of perioperative death for every size increase in women, a 1 centimeter size increase in women, there's an increased 18% mortality compared to men. And they, like I said, they lose EVAR eligibility. So because their proximal neck degenerates at the same size of around 5.5 in women, almost 60 to 70% of the women are not eligible for just an infrarenal device. Then you have to do a more complex device, like a fenestrated device that adds more perioperative mortality and morbidity. So the question for this trial is, should the same size criteria for AAA repair be used for women? And there have been 4 randomized trials that were done that compared if we randomized an aneurysm at 4 to 5.5 centimeters in size between surveillance versus early EVAR, is there benefit? And all the 4 studies were negative. But when you combine those 4 studies, only 4% were actually women. So based on data for 96% men, we have concluded that small aneurysms should not be fixed, but we don't know whether small aneurysms should be fixed for women. And so that's where the equipoise zone is. While there are risks for early repair that women do have worse outcomes with surgery, if we wait till 5.5, they have higher mortality, higher rupture risk. Usually, women tend to present with rupture at smaller sizes, and they also lose their eligibility for having a smaller procedure, which is an infrarenal EVAR. So should we be fixing it sooner? So this is the hypothesis of the Warriors trial. Women are treated too late in their clinical course, and the threshold for repair in women should be lower to be able to widely use infrarenal EVAR devices and to reduce AAA-related mortality, rupture, and detrimental effects on quality of life. Now, because women are not necessarily screened for aneurysms, especially in the United States, it's not approved. Only men with smoking history at 65 or older are approved. How do we find women with aneurysms? And how do we get enough power and sample size to answer that question? That's why this needs an international trial. So this is the Warriors trial design. So any woman age 50 years or older with that size threshold of 4 to 5.4 and suitable for EVAR, there would be randomization 1-to-1 between EVAR versus surveillance strategies. We hope to include 1,100 women overall internationally, but 350 of those we're hoping would come from the United States, depending on what happens with NIH and if it exists. And then the primary endpoint is aneurysm-related mortality or rupture at 5 years. And secondary endpoint is quality-adjusted life years, and also looking at anxiety and depression scales. And then we'll look at a whole host of other outcomes. This is the current global status. As I said, a lot of countries in the international trial coordinating centers at the UK and Imperial College have been approved. US application just went in October. Study section is in March, but I don't know if it'll meet. We'll find out. More to come. But as you can see, we started being part of these discussions back in 2022. It first had to go through an endorsement process for an international trial through Global Cardiovascular Research Funders Forum, and all these funding agencies were part of that. Then each of the countries applied for individual funding. We had to actually go through a process called staff consultation. So for any large clinical trial in the United States, you have to actually get approval from the institute that you're applying to on the trial design, the sample size, the statistical methodology, and budget before you actually can submit it for scientific review. So for that took us another 1.5 years, and we were able to then submit in this past cycle. So what makes this trial pragmatic? In the US, this is going to be a registry-supported trial. So what does that mean? We have a large vascular registry nationally called the Society for Vascular Surgery Vascular Quality Initiative. We already capture a lot of data on device interventions. So EVAR is its own specialty-specific module or intervention module. And we also have a medical management registry where patients who get randomized to surveillance can actually be housed. So to reduce the burden of data collection, the registry data has been harmonized with the case report forms of the trials. So the data that we collect will be entered into the registry and directly transferred to Imperial, thus reducing the amount of data we have to collect at sites. We've also identified sites which have high volume, and we did some preliminary analysis to show what are the EVAR volumes by centers at VQI and how many patients we could contribute. So the advantage of having a registry support this is you already identify sites which are high volume, which have existing infrastructure, which are seeing your patients of interest, and they won't have to go finding those patients. The third thing that's actually going to help us is the linkage of this registry with Medicare data. So a lot of the outcomes that we are assessing, mortality, aneurysm-related mortality, reinterventions, will actually exist in Medicare data linkage. So we've already done preliminary work. Dr. Goodney's group had done this to show there's 92% accuracy for EVAR-related follow-up events as they occur. So while we'll have sites open just for 3 years during which we enroll, the 5-year endpoint, the sites will actually be closed and all the data, primary endpoint data, will be collected through registry linkages and won't rely on actual on-site enrollment, thus reducing the cost of the trial a lot. Because keeping 35 sites open for 8 years is an enormous cost. And we were able to get equipoise from the VQI sites which were willing to do the randomization and a priori tell us whether they would be willing to randomize within the size thresholds that we talked about. So we had surveys that went out, which they answered. So there are examples of other registry-supported pragmatic trials in surgery. I think there was a study using the NSQIP data registry that came out in hepatobiliary surgery a few years ago where they randomized within the registry and looked at 30-day outcomes which were readily assessed through NSQIP. So it's very possible to use registries as platform for either case records, for data collection, for randomization, or for follow-up. And that reduces cost. It brings you to real-world scenario where you're addressing comparative effectiveness research questions in a real-world setting. There's enhanced generalizability. And you have rapid consecutive enrollment because these sites are already participating in a QI process, data collection process that you have deemed to be reliable to be included in your trial. And there's more completeness of follow-up if you have methods that, depending on what endpoint you are measuring. There are disadvantages. Your trial data would be as good as registry data quality, so you have to be very sure that the registry data quality is good enough to support the rigor of the trial. There are ethical issues. You have to get IRB consent and approvals that the data registry processes would be separate from the trial processes because patients are not being consented to be part of the registry, but for the trial, you do need a separate process to consent patients and ensure that you can identify those patients within the registry data. And there are other methodological challenges that, if anybody's interested, I can address at a later time. So I'll close out with some practical lessons that I've learned through these pragmatic trials that I've been involved in and researching others as I've been interested in the topic. I think it is very important to talk to senior trial PIs in surgery, get grant examples, talk exhaustively about your ideas so that you can work out those kinks and plan your trials. It is very important to engage statistical and trial design experts early. As you can see, pragmatic trials can be patient randomized, they could be cluster randomized, there are various design considerations, and whether you need a hybrid trial or an adaptable design, all of those things are up for discussion. Building networks for assessing sites' interest and resources is very, very important. You might have a site that has a large volume of the patients you're interested in, but if they won't take your phone call and they're not recruiting, that site is of no value to you. So building those networks and making sure that the people you are assembling, the sites that you're assembling, are truly going to believe in the equipoise of the trial, would be willing to randomize so that you don't have contamination, be willing to follow the site protocols and be able to course correct if they're not meeting recruitment targets, and be willing to put in resources, because for what we pay for clinical trials to actually happen, the sites have to put in a lot more of their own resources to actually do these trials. Building a reliable study team and finding a good trial manager, I can't say enough about that, because when you're operating and you're dealing with patient emergencies, your team in the background keeps all the day-to-day workings going. And meeting regularly with your team, sites, and collaborators is super, super important to have your pulse on what's going on the ground. And feedback is a gift. This is my general dictum in life. You have to ask for it and act on it. People who are willing to give you feedback are your friends. They're not judging you. They're actually helping you. And especially for overcoming barriers to recruitment and enrollment and understanding what are the pain points, how your trial could fail, you really, really want good feedback early and often and throughout. And celebrate the small wins. It's a long road to run these kind of trials. There's lots of setbacks. As I mentioned, my pause trial started during COVID, had to change the entire trial intervention to fit that. And got delayed by almost a year. Thankfully, the VA extended the funding for a year without adding costs. And then for the Warriors trial, we'll see what the future holds, but I'm optimistic. We'll hopefully this is a short-lived break, and we'll be back to doing our jobs hopefully soon. So in conclusion, pragmatic trials are much needed in surgery to assess real-world effectiveness of surgical interventions and treatment strategies to provide level 1 evidence. And there are various trial designs that can be used with advantages and pitfalls to consider, depending on your research question, your intervention arms, the underlying population of interest, and the need for adaptations. So thank you, and I'm happy to take any questions.